All right, so rounding out the first part of the morning, turn to some updates on the management of DCIS. So this is the current traditional approach to DCIS as part of the NCCN guidelines. A lot of wording, but it's basically a combination of surgery, which if you do breast conservation includes radiation, adjuvant radiation, followed by endocrine therapy. And as a review, these really stem from two NSABP studies, B17 and B24. So B17 was looking at breast conservation alone, lumpectomy alone, that's what the LO is. That's in the standard treatment arm here. And in the experimental treatment arm, it was lumpectomy followed by radiation. So this treatment arm of B17 is the standard arm or control arm of B24, where B24 added adjuvant endocrine therapy, tamoxifen, to the patients. And what you're seeing here are all the different types of recurrences and survival outcomes that were in the studies, either in the breast recurrence, invasive versus DCIS in the same ipsilateral breast, or contralateral recurrence, breast-specific mortality, or overall mortality. The top lines are the worst lines. That was treatment with lumpectomy alone. And when you added radiation, it cut the risk of recurrence in half. When you added endocrine therapy, which is the bottom line, it further decreased it by about half as well. But there was really no difference in overall mortality from this. So these studies form the basis of the NCCN guidelines and pretty much what we do right now. It's really important to treat DCIS because if it recurs, then half of the recurrences can come back as invasive cancer. And these are survival. This is the cumulative incidence of death that's occurring for patients with either recurrent invasive cancer after previously treated DCIS or recurrent DCIS after a previously treated DCIS. And this curve is much higher, 7 times more likely at 5 years. You can see about 6% versus 1 to 1.5%, 7 times more likely to die of invasive breast cancer if it comes back after a previously treated DCIS. So it's important to still treat this. When it comes to the choice of endocrine therapy, postmenopausal typically receives aromatase inhibitors, premenopausal typically receives tamoxifen, and then this was a study looking at just that, looking at anastrozole versus tamoxifen. This was B35. These were in postmenopausal women, and you can see kind of a split in the curve later, like 10 years later, showing a benefit from anastrozole, the top line, versus tamoxifen. That's not a huge split, but it was much more beneficial when they stratified